Hey everyone, welcome back to Shock Doc Medical. I'm Dr. Rod, and today we're diving into a topic that touches nearly every teenager, and even many adults, in a big way: acne. Now, have you ever wondered how a skin condition that starts at age 12 can evolve into a lifelong battle, affecting not only your appearance, but also your self-confidence and even mental health? Well, stick around, because we're breaking down everything you need to know about acne, from its causes and presentation to the nitty-gritty details of diagnosis and treatment. This episode is jam-packed with insights for both patients and doctors, so grab your coffee, relax, and let's chat like old friends over a long, fascinating conversation about one of the most common yet complex skin disorders out there. Let's start with the basics. Acne is a disfiguring disorder of the pilosebaceous unit that usually kicks in between the ages of 12 and 14. Almost every teenager has experienced it to some degree. And guess what? It can stick around into adulthood, especially in older women, where we seem to be seeing more cases. The pathogenesis of acne is multifactorial, meaning there are several players involved in triggering that chronic inflammation around our hair follicles and sebaceous glands. And trust me, it's not as simple as just getting pimples. There's a whole world behind it. When you're faced with a patient struggling with acne, there are some key questions you absolutely must ask. It's like being a detective trying to solve a mystery. Here's what you need to know. When did the acne start? How bad is it today? This gives you a timeline and helps you gauge progression. What impact is the acne having on the patient's life? Remember, acne isn't just skin deep. It can erode self-confidence, lead to depression, and in severe cases, even push someone towards suicidal thoughts. What treatment has the patient used and for how long? Most treatments take up to 4 months to show maximal effect, so patience is key. How are topical preparations, such as benzoyl peroxide or topical retinoids, being applied? Are they being spread all over the face and trunk as they should be, or just on the spots? And are there any adverse effects like skin irritation? What about oral antibiotics? Many patients need prolonged treatment for years. Clarify what the patient means by taking a course. What else is being applied to the skin? Greasy cosmetics or pomades can worsen the situation. What's the patient's occupation? Working in hot, humid environments, handling tars or oils, or wearing occlusive headgear can all aggravate acne. Is trauma irritating the hair follicles? Think about friction from chin straps, helmets, shoulder pads, as seen in American footballers, or even overzealous exfoliation. Is the patient taking any drugs that might exacerbate acne? Some medications can really make acne worse. We'll get into those in a minute. And finally, consider the possibility of refractory severe acne. This might indicate something more complex is going on. These questions help build a complete picture and ensure nothing gets overlooked. Now, aside from the questions, what should you actually look for during the physical exam? Here's a checklist. Distribution. Acne typically affects the face and upper trunk. If you see an unusual or asymmetrical pattern, think about external factors that might be involved. Lesion types. You might encounter pustules, papules, comedones, blackheads being open comedones, whiteheads being closed, nodules, cysts, and scars. Make sure to record the types of lesions. This helps you monitor treatment outcomes. Predominance of comedones. If comedones are the main issue, it could suggest exposure to tar or chlorinated hydrocarbons. Think about pomade acne on the forehead. Signs of virilization. Look for hirsutism, and in females, even clitoromegaly if you suspect hormonal imbalances. Associated syndromes. Keep an eye out for signs of Hair-Ann syndrome. Long-term effects. Even mild acne can lead to acne keloids, or in darker-skinned individuals, long-lasting hyperpigmentation. Be cautious. Prolonged courses of minocycline can sometimes cause hyperpigmentation and scars. And don't forget, always consider the clinical variants of acne, which we'll dive into next. Let's talk about why acne happens. The pathogenesis isn't completely understood, but several factors contribute. Increased sebum excretion. There's an overproduction of sebum, which can remain high even after acne clears. Androgens. Hormones like testosterone stimulate the sebaceous glands to produce more sebum. Follicular duct occlusion. Hyperkeratinization can block the ducts. This is often made worse by applying greasy products or tar. Bacterial colonization. The culprit here is Propionibacterium acnes, a commensal bacterium. It breaks down triglycerides, releasing free fatty acids that trigger inflammation. Plus, it activates toll-like receptors on keratinocytes, adding fuel to the inflammatory fire. FGFR2 signaling, increased fibroblast growth factor receptor 2, FGFR signaling, often upregulated by androgens, plays a role here. Mutations in FGFR2, like those seen in Apert syndrome, can lead to severe acne. Genetics. About 50% of patients have a family history of acne, so there's a genetic component. Diet. There's a suggested link between dairy products and acne, but more research is needed. It's a multi-hit process, and understanding it can help tailor treatments more effectively. Acne isn't a one-size-fits-all condition. There are several variants you need to know about. Acne, excoriae de la jeune fille. This is seen in young girls with mild acne who obsessively pick at their skin. It can be really difficult to manage. Even mild cases may need systemic treatment. Neonatal and infantile acne. Usually affecting the face, it can persist until age 3 or 4. And remember, inhaled corticosteroids can sometimes be the culprit here. Acne conglobata, a severe form characterized by grouped comedones, deep nodules, and abscesses with sinus tracts oozing pus. Acne fulminans. This variant comes with nodulocystic acne, fever, and joint pains. Sappho syndrome stands for synovitis, acne, pustulosis, hyperestosis, osteitis, an important but rare condition to consider. Papa syndrome and Pascoe syndrome. These are rare autoinflammatory diseases featuring acne along with systemic symptoms like pyoderma gangrenosum or hidradenitis suppurativa. Chloracne. Acneiform lesions resulting from exposure to dioxins or chlorinated hydrocarbons. Each variant has its own nuances, so being aware of these can really guide your management approach. Sometimes, acne isn't just a hormonal or bacterial issue. It can be induced or worsened by certain drugs. When you see an acneiform rash, especially if it's primarily on the trunk and outer arms without any comedones, think about medication-induced acne. Some of the usual suspects include antiepileptics, such as phenytoin, carbamazepine, and gabapentin. Anabolic steroids, drugs like danazol and testosterone, often seen in athletes or bodybuilders with treatment-resistant acne. Antitubercular drugs, isoniazid is a known offender. Cyclosporin. Corticosteroids, including inhaled forms or even those delivered via a face mask in young children. Epidermal growth factor receptor inhibitors, used in certain cancer treatments. Growth hormone. Halogenated compounds, such as iodides, radio-opaque contrast materials, and bromides in sedatives and analgesics. Lithium. Progestogens, for example, medroxyprogesterone. Vitamin B12, cyanocobalamin. Always ask about current medications, as this can help you pinpoint the cause and adjust treatment accordingly. Now, let's get into the heart of the matter. How do we manage acne? The approach varies based on the severity of the condition. Whether you're a patient or a clinician, understanding these steps is crucial. All patients the basics. Provide written information. Reassure your patients that their skin isn't dirty and that help is available. Set expectations. Explain that most treatments take 3 to 4 months to reach their full effect, and sometimes the acne might even worsen before it gets better. Patience is key. This could be a months or years-long journey. Psychosocial impact. Always assess how acne is affecting your patient's mental health. Referral to mental health specialists might be necessary. Assess for scarring and pigmentation. Early intervention can help mitigate these long-term sequelae. Seborrhea check. High sebum levels can predict a poor response to antibiotics. Counsel on skincare. Recommend gentle cleansing and avoidance of comedogenic products. Look for comorbidities. Consider underlying endocrinopathies, such as androgen excess or drug-induced causes. Mild acne. Topicals are your friend. For mild cases, start with 1 or more topical preparations. Combination therapy is usually more effective than monotherapy. Key points. Application. Make sure patients apply the treatment all over the affected areas, not just on individual spots. Duration. Continue treatment for at least 4 months, often longer. Topical options include antibiotics, erythromycin or clindamycin lotion, benzoyl peroxide. Use a 2.5% preparation. It's effective and less irritating than higher percentages, although it can bleach clothing. It can be combined with a topical retinoid. Topical retinoids. Options include tretinoin, isotretinoin, topically, not to be confused with the oral form, or 0.1% adapalene, a retinoid-like drug. Note, these are irritants and may cause post-inflammatory hyperpigmentation in dark skin, so advise patients to gradually increase contact time, starting with a 30 to 60-minute application before washing off. Moderate acne. Adding the systemic punch. For moderate acne, consider systemic treatment along with topicals. Oral antibiotics, used for an initial 4-month course. Options include oxytetracycline, 500 milligrams twice daily, limecycline, 408 milligrams per day, or erythromycin, 500 milligrams twice daily. Always combine with topical benzoyl peroxide to reduce bacterial resistance. Note, do not combine with another topical antibiotic and avoid tetracyclines in children under 12 years. For females, an oral contraceptive with anti-androgen activity can be very effective. For instance, cosiprindiol is a good option, but remember, it can take up to 6 months for maximal effect. Avoid contraceptive pills containing norethisterone due to their androgenic properties. Severe acne or acne with major psychosocial impact. When acne is severe or significantly affecting quality of life, referral to a specialist is key. The gold standard here is oral isotretinoin. Dosing is typically 0.5 to 1.0 milligrams kilograms per day, with a cumulative dose of 120 to 150 milligrams per kilograms. A couple of things to note. Teratogenicity. It is absolutely teratogenic. Women of childbearing age must use effective contraception during treatment and for at least 1 month after discontinuation. Adverse effects. Expect mucosal dryness and, very rarely, depression. For cysts, intralesional triamcinolone injections can be very effective. Typically, use 0.1 milliliters of a 2.5 to 10 milliliter solution. Addressing scars. Shallow scars often become less obvious with time. Consider referral for cosmetic camouflage. Resources like Changing Faces at changingfaces.org.uk can help. Deep scars. Surgical approaches such as chemical peels, lasers, or dermabrasion may help, but these aren't available through the NHS and should only be considered once acne is under control. Let's break down the treatment strategy into clear steps. Step 1. Combination topicals. Studies show that combination topical therapies outperform single agents. The principles here are: use a combination of a topical retinoid and an antimicrobial. Avoid using antibiotics as monotherapy. For any severity of acne, fixed combination options: adapalene with benzoyl peroxide, Epiduo; tretinoin with clindamycin, Treclin. Use daily. Alternating days or using short contact times can help improve tolerability. Mild to moderate. Combination benzoyl peroxide with topical clindamycin, DUAC once daily, is a solid option. Topical benzoyl peroxide monotherapy. This can be an alternative if the fixed combinations are contraindicated or if the patient wishes to avoid a topical retinoid or antibiotic. Step 2. Moderate to severe disease. Topicals plus systemic agents. Here, you combine a non-antibiotic topical with systemic antibiotics. Option 1. Oral tetracycline. Either limecycline 408 milligrams once daily or doxycycline 100 milligrams once daily, along with a fixed combination topical adapalene and benzoyl peroxide, Epiduo. Note on minocycline. Although widely used in the US, its side effects and cost limit its use in the UK. Azelaic acid. Products like Skinorin or Finacia, applied twice daily, can be used as a second-line topical. Option 2. Alternative antibiotics. If tetracyclines are contraindicated, macrolides such as erythromycin 500 milligrams twice daily for 12 weeks can be used. Less commonly, trimethoprim 200 to 300 milligrams twice daily for 12 weeks might be an option, but be cautious of severe cutaneous adverse reactions. Option 3. Combined oral contraceptive pill, COCP. All COCPs seem to perform similarly in treating inflammatory acne. A meta-analysis shows they have efficacy comparable to oral antibiotics at 6 months. However, consider the patient's risk profile and ensure appropriate contraception if combined with isotretinoin or tetracycline. Refractory acne, isotretinoin. This remains the cornerstone for refractory acne. Refer to established guidelines for dosing and management. For severe cystic acne, oral prednisolone, for example, starting at 20 milligrams with a reducing dose over 4 weeks, can be used to prevent a severe initial flare. Spironolactone. Although robust evidence is still pending, case series suggest benefit in adult female acne. A large NIHR HTA study has been conducted. Stay tuned for those results. Acne relapses after isotretinoin. Watch for patients likely to relapse, such as younger individuals, those with truncal acne, a family history of severe acne, or underlying endocrinopathies or androgen excess. Consider maintenance therapy with a combination topical retinoid and benzoyl peroxide for these high-risk patients. Before we wrap up, here are some clinical pearls to keep in mind. Alternate day application. Using topical retinoids on alternate days and with short contact times can reduce adverse effects. Skincare regimens. A good regimen supports treatment adherence. Cleanse gently and avoid comedogenic products. Antibiotic stewardship. Never use antibiotics, topical or oral, as monotherapy. This reduces the risk of antimicrobial resistance. Watch out for gram-negative folliculitis. Long-term antibiotic use can sometimes cause this. If multiple pustules develop after a good response, get swabs for microbiology. In such cases, isotretinoin is the treatment of choice. Isotretinoin tips. Low-dose isotretinoin at the start is associated with fewer acne flares. Also, remind patients that isotretinoin is better absorbed when taken with food, ideally a fatty meal. Taking it on an empty stomach can reduce absorption by up to 60%. Triamcinolone injections. These can be very useful for severe nodules or cysts. And one more thing. If severe acne isn't improving, revisit the history. Ask if they're using any skin products or if they're taking drugs like anabolic steroids. Also, consider underlying conditions. Polycystic ovary syndrome, PCOS. Look for obesity, oligomenorrhea, infertility, and hirsutism in females. Congenital adrenal hyperplasia. Rare, but caused by 21-hydroxylase deficiency. Androgen-secreting tumors. These can occur in the adrenals, ovaries, or testes. XYY syndrome. Consider in tall males. Apert syndrome. Look for associated features like low IQ and acrocephalosyndactyly. Wow, that was a deep dive into acne, from its origins and clinical presentations to detailed management strategies for every level of severity. Whether you're a patient struggling with acne or a fellow clinician looking for guidance, I hope today's discussion has given you a clearer picture and some actionable insights. Remember, acne isn't just a cosmetic issue. It can have profound psychosocial effects, and effective management is about more than just clearing your skin. It's about improving quality of life and self-confidence. If you found this episode helpful, please hit that like button, subscribe to Shock Doc Medical, and drop your comments or questions below. I love hearing your thoughts and experiences, and it helps build a community of curious minds passionate about medical advancements. Next week, we're going to uncover another groundbreaking discovery that might change everything in dermatology, so be sure to tune in. I'm Dr. Rod, signing off. Stay informed, stay curious, and keep challenging the norms in medicine. Until next time, take care of yourselves and your skin.